Hi, my name is Mike Govin and I'm from Team Space. With me today is Lyric Jordan, Talia Coate, and Julie Shea. The aim of this project is to determine what methods were most effective in connecting with our patient during our telehealth visit. Telehealth is an emerging service that is being utilized now more than ever as it is being used to reduce the spread of coronavirus. Although telehealth increases access to healthcare for some, others may not have access to devices capable of virtual communication or may not be comfortable using such devices. It is unknown if health outcomes are better or worse with the implementation of telehealth, so we hope this experience will shed some light on how it can be used appropriately in today's world.
In order to complete this pilot study, we surveyed IPTI Team 2 members consisting of 4 girls and 2 boys through an anonymous survey platform. Participants were asked to recall their IPTI telehealth sessions and answer questions on what methods they used to establish a connection with the patient and which method, if any, they felt was effective. The survey revealed that the top 3 most utilized methods by Team 2 were positive reinforcement and words of encouragement, humor, and involving other team members in the conversation. However, the majority of the group reported that talking about the patient's personal interest was the most effective way to establish a connection with them.
Telemedicine has become a vital part of patient access and communication, but it also has its challenges. Team Space found that connecting with patients was significantly harder than in-person encounters. The team found it critical to connect with the patient on a personal level in order to establish a relationship. Once the patient felt comfortable with the providers, he was able to open up about his goals and medical concerns. The encounter also emphasized the importance of time. By being able to interact virtually, it gave the patient access which would not have taken place otherwise. We learned that in order to do our jobs as medical providers, we have to treat the person as a whole and learn who they are before addressing their medical concerns.
So, in conclusion, our team really saw that humor, shared interests, a strengths based approach, and an interdisciplinary collaboration really had the highest impact on building a positive rapport during our simulated telehealth experience. And for future studies, it would be really helpful to have a larger sample size to really see what factors contribute to this positive rapport on telehealth, especially as they increase. So we really want to thank Interprofessional Team Immersion for giving us this opportunity to work on a team. And also, we really want to thank our faculty mentors, Dr. Cramsey and Dr. Albina. Thank you so much for listening. Thanks for listening. If anyone has any questions or comments.
So team 2, great job on your presentation. I am curious if any of your team members are willing to share it sounds like there were some challenges just making those connections, as well as some things that you anticipate bringing into your future practice. So if you don't mind just kind of recapping sort of what the challenges were and what you think mitigated those and how you'll use it in the future.
I wasn't sure if my volume was off because it was quiet, and I'm like, is my volume working? So I think that one of the biggest takeaways, which we said, was just the importance of establishing a connection. And I know for me, as someone who wants to go into pediatrics, telehealth has been a major uprising thing because you don't have to bring a patient into the chair to have these desensitization appointments. So I feel like not only did I practice the ways to establish a connection over telehealth, but also it just reconfirmed the importance of getting to know your patient on a more personal level and not necessarily just on a medical level. That's something that I will definitely carry forward with the rest of my career, whether that's with adults, pediatrics, geriatrics. I think it's very beneficial. And I really hope that groups in the future that do team immersion look at this and think maybe they could take this sort of pilot study and grow it and be able to pull more than just their specific IBTI group. I think that would also be really helpful.
Yeah, I think going off of that, in the beginning, it was kind of, I think, uncomfortable for us because it might have been one of our first telehealth experiences or just like working on an interprofessional team. And I felt like like not being in person, it was hard to kind of like try to gauge eye contact and body language, especially based off of like where the camera was for our patient. So it really did help us just kind of like use that humor and like use our shared interest to kind of get the ball rolling and kind of like break this almost like too professional of a medical team, just to kind of be like, we are humans too, like we want to get to know you and we also like want to be able to help you.
I'll ask a question. Were there any surprises or unexpected outcomes in this? Something just really took you, you weren't expecting?
I think what wasn't surprising, not to flip your question, was the results of what everyone found to be most effective. However, when we surveyed our group in the most utilized methods, establishing that personal connection with them actually wasn't one of the highest results. So that was definitely surprising because the methods we were utilizing and thought that would be important, like asking about their medical history and things like that, weren't what showed up in the results. So that was a little bit contradicting, but it was a pleasant surprise, I think.
I think to answer Dr. Cramsey's question, just being able to, I think I think it was Talia who asked him like, oh, what's your hobby? And he kind of said guitar. And I feel like it just kind of like turned into like, oh, like that's awesome. And we just started rolling with like where the guitar stores and stuff like that were. And like things just kind of got really so much more comfortable after that question. And it was just such a simple question, but it was so helpful to like make a good connection.
Yeah, I think really how it showed how important it was to read body language even through telehealth, because he was a very monotone patient. And when we brought up the guitar, his body language, opened up. And I think being able to read that and saying, oh, I think he wants to talk more about that, and taking that idea and running with it was essential for us to be able to actually provide good recommendations for his mental health and his total well-being, because we were able to tie the interest of guitar into his job search and other things like that, which was really helpful.
Just to get the ball moving, you can move to different breakout rooms if you want, but I'll be putting up a new transition slide, and the next one starts at 12:20.
Hello, my name is Brandon Thompson, and I'll be joined by my colleague Aaron Walsh as we discuss and share our poster presentation with you all. Special thanks to Dr. Thomas Mauser, who served as the principal faculty investigator of the present study. The title of the study is Self-Reported Cognitive Decline, Differentiating the Worried Well from the True Cases. Understanding the differences between normal age-related changes in memory and thinking versus cognitive change that might be associated with diseases such as Alzheimer's or dementia is important, especially in an era of continual medical advancement that has resulted in an increase of our elderly population. Cognition changes in normal aging adults typically results in slower, less accurate decision-making or processing external stimuli at a slower rate. Age-related diseases such as Alzheimer's accelerates the decline in neuronal functioning and consequently cognitive decline, which has a detrimental impact on the individual's ability to perform activities of daily living. Participants of the study were selected by the study coordinator and the director for the Center for Excellence in Aging and Health. Study research teams are made up of a variety of health professionals, including social workers, pharmacists, and occupation therapists. Phase 1 protocol involved a short interview with the participants that assessed their reason for participating, their hearing and vision, daily life, health, and cognition. This was followed by the testing portion of the interview, which involved 6 cognitive tests. Pictures of these tests are shown here on our poster. Data was then collected and analyzed to determine if participants would be categorized as true cases or worried wells. We utilized these preliminary results to select certain participants to complete a Phase 2 interview process. We plan to analyze this data as a whole and will leverage our findings to not only assist those who are true cases to find a path to proper treatment, but to advance our knowledge of normal cognitive aging and other changes associated with true cognitive diseases. Thank you.
Thanks for that overview of our study in phase 1, Brandon. I'm going to take over from here to discuss phase 2 and some preliminary outcomes. After phase 1 was completed, participant scores were analyzed. 72.5% of the participants fell into the worried well category, whereas 15% were considered likely true cases and 12.5% possible true cases. A subset of 20 participants were chosen for a phase 2 follow-up interview. The aim of phase 2 was to further understand the participants' activities, health, and wellness in the context of their daily lives. Finalized results from phase 1 and 2 are expected to be released this summer and will answer questions like, do persons identified as a true case differ from persons identified as a worried well in terms of health conditions? Our hypothesis is that true cases will have evidently more health conditions than worried well, and that the types of health conditions will differ between the two as well. We expect the true cases to present with more CNS and heart-related conditions than the worried well. Thank you all for listening to our brief synopsis of our ongoing study. We welcome any questions you may have during our breakout session.
All right, thank you for listening, everybody. We'll take your questions, and I'll post the poster in the chat as well if you guys want to take a look.
So nicely done, folks. I'll go ahead and pitch questions. So as you got to know these people during the interview, you may have developed kind of a sense for them, and then you tested them and learned actually how they performed. And I'm wondering if you experienced any disconnects between how the person presented to you and then what you actually experienced with their testing in terms of maybe those that struggled and didn't do as well. I'm curious if you have any reflections on the clinical experience of assessing someone suspected of having cognitive impairment.
Yeah, I can start with that one, Dr. Meeser. That was a really great question. I think it really kind of depended on where we were in the interview with the patient specifically, and kind of if you guys were in the breakout room for the first presentation, I think it kind of associates with that. If we're talking to a patient who might be kind of closer to the side of a true case, but we were talking to them about something that they're interested in, they seem to be a lot more engaged and involved in the questions regarding that. But if it was something, you know, more about their health and how they're feeling about it, for me personally, I think I started to notice a little bit more of a disengagement in the patient. Whereas with the worried wells who didn't really have any true dementia symptoms going on, regardless of what type of question was being asked, they seemed to be pretty consistently engaged in the interview process throughout.
I'll keep the conversation going, hopefully. So as an OT faculty member, I'm just curious what it was like to give 6 different assessments to the individuals, and if you had familiarity with those tools prior to this project, what it was like to learn them and then to implement them.
Yeah, I'll take this one. For me, I've never had experience administering a cognitive test before. So the process was definitely new for me, but I thought it was a very enlightening experience. I enjoyed my time working with I work with a social worker, which is great. And in terms of administering the test, it took some practice. So we had some practice sessions to make sure what we're doing was correct. And once we got rolling, like the first couple were a little difficult, but once we found like our groove, we could just do it pretty easily, and it was very, very seamless working together with my partner. So overall, it was a really great experience.
Yeah, if I could just kind of, go right ahead, Dr. Dornblaser.
I was just going to follow up on if you could talk a little bit about how having this be an interprofessional experience maybe impacted the learning that you guys had.
I was actually my response is going to go right there. I was going to say, you know, as pharmacy students like Brandon and I are, you know, initiating these cognitive tests is something we aren't trained in. We're the medicine people. We do a lot of these point of care testing, things like that, nothing super cognitive. So to take these extra Zoom meetings to learn these cognitive tests and stuff, it really gave me more of appreciation to our occupational therapists and our other interprofessional team members. It really gives you more of an insight as a pharmacist to potentially what medications they may need, may not need, just based on these cognitive tests. So it really just opened my eyes more to really how important an interprofessional team is to treat a patient to the best of our ability.
And from an OT perspective, to hear that like what my results from like these cognitive screens would like change the medication that you're gonna give, that's interesting as well. Like, I know, a little tangential, but
Thank you, everyone. This is your time to stay here or go into a breakout room. That was an awesome presentation.
Thanks, everybody.
Thank you.
Bye, guys.
Hello, and thank you for joining us. We are pleased to present our poster on medications and cognitive aging in community-dwelling older adults. My name is Emily Poirier, and I'm a third-year pharmacy student.
And my name is Carly McKenna, and I'm a second-year Master in Social Work student.
Carly and I participated in a study of cognitive aging led by Dr. Muser as an assessment team. Our role was to meet with community-dwelling older individuals via Zoom and administer a testing protocol. I was interested in the relationship between the presence of potentially inappropriate medications in older adults as identified by the Beers list and cognitive patterns. Our purpose was to identify if there's an association between the use of Beers list medications and associated factors and indicators of cognitive impairment in community-dwelling older adults who report subjective memory complaints. The data that we collected from each of the participants was analyzed using correlation and mean difference statistics. We expected to see a relationship between participants taking Beers list medications and worsened cognitive testing scores. However, no obvious relationship was identified. We did find one correlation between anticholinergic burden score, which is the sum of all anticholinergic medications, and the short blessed test. Our analysis also indicated a correlation between polypharmacy, which is the use of multiple medications, and possible cases of cognitive impairment.
We have examined one of our participants with the possible cognitive impairment more closely. This is Jane Johnson, and she is an 81-year-old Caucasian female. Please refer to our poster for more of a social history on Jane. And Jane reports the following health conditions: hypertension, arthritis, history of smoking, and suffers from poor sleep. She is prescribed the following medications to treat her health conditions: metoprolol, lisinopril, and HCTZ. She also reports taking over-the-counter Benadryl. In January 2021, Jane participated in the following. She reported a worsening of her memory and thinking, particularly with remembering names, and she reports no family history or memory difficulties or cognitive changing or decline. Jane was given numerous cognitive tests over Zoom, and she took the SAGE and scored a 16. The score of 16 on the SAGE is consistent with mild cognitive impairment, and as previously mentioned, Jane takes Benadryl, which is identified as a highly anticholinergic medication by the Beers list, and can contribute to cognitive impairment, confusion, or sedation. While we did not find the results or get the results that we expected, this was just a small sample study that was good for first step and provided a lot of pilot data for a larger research study that Dr. Muser plans to pursue.
Thank you for sharing. Does anybody have any questions or comments? I guess I have one. Dr. Muser, for your future research, is there anything from this study that you're going to change about that, or just kind of think about a little bit more based off of these findings?
Sure, thanks for asking, Julie. So we all hear these warnings with medications. It might affect your driving, or don't operate heavy machinery or whatnot. And we generally think about certain medications as not being appropriate for older adults. And I dropped a copy of the Beers list link into the chat for those that want to look it up. It's actually good for all health professionals to know something about Beers list drugs. Our sample size was too small probably to see much of a signal, although in the case that Carly read, we definitely had a recommendation, time to stop Benadryl for this one person, probably. At least it's something that she needs to take back to her primary care doctor. The hope is that we can get a grant to do a much larger community sample where we can both test people and learn about their medications and see a signal for drug impacts in the future. And I'll ask a question of Carly, just, so you, as a social worker working in an interprofessional team, you evaluated these participants. What was it like working with somebody from a pharmacy perspective in this? And did you learn something new about that you didn't know before?
I give all pharmacy students a lot of respect for pronouncing any of the medications. Emily was really kind and generous with how many recordings that we did for me to even come close to it. But just from a medical perspective, it was really fascinating to see, what Emily picked up on during the interviews versus what I would pick up on in terms of, mental health and social setting and people like relationships, whereas Emily was more focused on, the medications and how they're working together and how they could be affecting her cognitive change. So I did learn a lot.
Yeah, terrific. Thank you. Any last questions for Carly Rye? Since there's time, I'll mention that Emily Poirier wanted to be with us, but she's traveling to see her family today and couldn't participate.
My name is Faye. I'm a social work student.
I'm Corey. I'm an occupational therapy student.
My name is Christine. I'm also a social work student.
And we're going
to... For our project, we created a body map.
So here it is. So a body map is an arts-based social work intervention. It's used with a number of populations from LGBTQ youth to sex workers to immigrant communities. What you do is you'll start with the outline of your body, and the inside is going to represent your values, what's important to you. The outside is going to represent your supports, who and what are important to you and support you. So we decided to do it for each of our fields, and we'll have Corey start with the occupational therapy.
So on the left there, I'll start with the inside of my outline. I do have a tree that represents family. I've always grown up around animals. I enjoy traveling and hiking. And on the outside on the left, I have AOTA, which is our governing body, which is the American Occupational Therapy Association. I have some popular models that we use. I have also different technologies that we might use in practice, and also different drawings representing everyday activities that we may do with clients. And on the bottom there, I have the Just Right Challenge, which is something that we strive to do with each client.
So for the social work side, Faye and I did ours together. So our inner body represents, the things that helped us get to our social work career. So we both like to help people, as well as we have interests in being outdoors and spend time with our pets and family. And on the right-hand side, on our outer body, we have the things that we care about in our fields, which is social justice and policy issues. And on the bottom, it shows the theories that we use. We do micro, meso, and macro work. We do work with motivational interviewing and polyvagal, and we also create safety plans.
And on this area here that is in between us, we represented the aspects of our fields that overlap. So we do mental health work, CBT work, communication is very important, client-centered care. We work with families, we work with evidence-based practices, ethics is important, and mindfulness is important for both of our fields. And up here, we work in a lot of different settings. And that was our project, and thank you. That's our time.
You kind of talked about, I think it was one of the social workers, you kind of talked about how it's done in practice. Is there like typically like a age range, or is it more like a type of situation that the client is that you would use this the most, or is it just?
Use body mapping?
Mm-hmm.
It's been used with youth, but also adult populations. There was I think Indigenous women in Canada, there was a body mapping thing that went for like a couple of days, and each woman made their own map. So yeah, really any age.
Was there anything that surprised you? Sorry to cut you off. But was there anything that surprised the group about like what each person put in the middle or like anything?
Yeah, I think that we were surprised that we had so many similarities between our fields, kind of seeing, the things we're like, oh yeah, we do this. And like, do you also talk about this? Or, and some of them are pretty obvious, like client-centered work and, but evidence-based practice also, and mindfulness and, obviously we all work with family systems. So it's just a lot of similarities that we didn't really think about or realize until we started doing this project.
Thank you guys for a great presentation. It sounds like you gained a lot of positive outcomes as students, learning about and appreciating each other's professions. I'm wondering, in practice, what are some of the positive outcomes that result from body mapping interventions?
It can be a useful, arts-based social work can be really useful for groups that are going to get something out of doing art creative work. So like populations that don't like immigrant populations who maybe the people who are if they're doing it here and they're not from the US, maybe they can represent more with pictures and drawings. And, it's like a sense of accomplishment. You've made this beautiful work of art and it represents you, and it's kind of can give you just a sense of, I guess, accomplishment and satisfaction.
Thank you guys.
I'm also wondering from like the OT perspective, like if this could be helpful, like we talk about interoception a lot. I don't know if this came up like while you were just like making this, but like kind of understanding like what is going on inside of your body, like what those feelings are. And if that could, like, even using like this body mapping could help with kind of understanding like, why does my stomach hurt? Why does my arm feel like that? Or why do I feel so like anxious right now? So it was really cool to see that visual of like all the things that you love. And yeah.
I also think, doing this, I learned a lot about kind of this way of doing things. So I think it can give people a lot of voice too. So also kind of, having those representations of things that they may want to talk about or they may not feel comfortable talking about. I thought that was really great too. Yeah.
So I'm curious, of the three of you that did the body mapping, do you feel like you're creative? Are you somebody who seeks the arts, or was this outside of your comfort zone? And how might that translate or not to clients that either feel like they're crafty or creative, or perhaps more nervous about what the outcome is? Because the products are beautiful.
I can say that I am not artistic at all, like at all. Like, I can see a photo. I had my phone up and I was Googling photos on, interpreting what I wanted to kind of say. And then when I would draw it out, I was, at the very end, I was very proud of our work. I was actually in awe of it. I stared at it a lot. I kept like referring back to like, look at what we made, and it made me feel really great that we were able to do something and put together. I think having someone facilitate the body map who is, interested in art. We had Faye in our group who was interested in art. Really kind of brought like, she kind of taught us how to do certain like painting strokes and how to blend colors. And I think that part was really fun.
Thank you so much. And this is kind of a time to stay in this room or move to a different one if you'd like. And the next one starts at 12:47.